Welcome to the 12th International Dementia Conference. I'm Sinead Brennan and I'm your host today. I'm CEO of Engaging Dementia. Kim Tully, who's actually taking over from me later this week when I start an academic sabbatical, is hosting alongside me for this two-day event. So we're having a two-day event, and then on Wednesday, there'll be a policy and practice forum that's being run by the Dementia Research Network of Ireland and the HSE National Dementia Office. So at the three-day event, we have more than 40 speakers from Ireland and abroad. I'd like to welcome and thank our academic partner, Professor Kate Irving from the School of Nursing, Psychotherapy and Community Health in Dublin City University. The other members of our advisory panel, that's the HSE National Dementia Office, the Dementia Services Information Development Centre, Alzheimer's Society of Ireland, Global Brain Health Institute, the Research Network of Ireland, and Nursing Homes Ireland. I'd like to thank our sponsor as well, Homestead Senior Care, and especially Richard Mullins. So just a few words about Engaging Dementia. Well, for 25 years, we've brought training, advice and support to caregivers and care partners in residential care and community care through education, resources and community activities. Our mission is to facilitate engagement and connection for people with dementia and their care partners. Our vision, an Ireland in which people with dementia and their care partners and families are living life to the full. Our activities are focused on improving well-being, especially through the use of music, sensory stimulations, the outdoors, the creative arts, the Sonus program, which is our core program, and that's a therapeutic activity for people with later dementia. We're also involved in a really exciting project at the moment, the establishment of an Irish Dementia Cafe Network. That was a project that is commissioned by the HSE National Dementia Office and funded through Hubble Dormant Accounts through the Department of Health. And Professor Eamon O'Shea, who is here today from the Centre of Economic and Social Research in Dementia, the establishment of the network was very much built upon the Centre's research, the establishment of the network. So I suppose this has been an extraordinarily challenging time for people with dementia and their care partners. So at our conference, we will be covering many aspects of care and supports and services, and we want to share to facilitate sharing of knowledge, best practice and innovation. Just a few logistical points. There are two virtual rooms. So we have a plenary room and a parallel session room. And they're running alongside each other. So you will have received an email and you'll have links to either one. So feel free to, tune in and out to whatever sessions that you would, that you're interested in. We're going to be recording them all afterwards if technology obliges for us. And we'll put the recordings up on Engaging Dementia's YouTube channel. So I would like to now welcome our speakers. So our speakers are Professor Eamon O'Shea from the Centre for Economic and Social Research in Dementia, Professor Des O'Neill, who's consultant geriatrician in Tallaght University Hospital, Deirdre Lang, Director of Nursing and National Lead for Older Person Services Clinical and Integrated Programme in the HSE. And we have Deputy Chief Inspector of Social Services at the Health Information Quality Authority, Susan Cliffe. So welcome to all of you and thank you so much for joining us today. So I'm now going to introduce the speakers one after the other, and then we'll have a panel discussion at the end. So I'd encourage people to use the chat functions. There's a chat and there's also a Q&A button, and people can submit comments and questions through the chat. So the speakers can pick up on them themselves, or we can wait until the end and then we'll pick up on all of them at one time. Okay, so I will now introduce our first speaker, Professor Des O'Neill.
Thank you very much, and I'm really pleased to be here. Fantastic program, And while it's a shame that we can't be here in person, by removing the barriers of travel and time, it means much more of us can make much more of these meetings. And I think we've really got to see the positivities that we can find. So what I'm going to do now is, in a word, is to try and get a sense that while we know that COVID-19 is the great revealer, perhaps we need to think about not only what it reveals about things outside the service, but for us, largely a group involved with advocacy, the professional side, the research side, being care partners, what does it reveal about us and our way of viewing the world and life with dementia? Very often at the beginning of conferences, we're supposed to put up a slide of a conflict of interest, but often they're confluences of interest. And I'm deeply interested and aware in the issue of our own skin in the game, given that we all have probably a 1 in 10 or thereabouts chance of developing dementia at some stage in our life. And all 4 of my grandparents here on the left, my paternal grandparents, developed dementia. While I was a child, I had experience of them, and I always saw them as positive, complete, whole people with barriers of memory. Perhaps it was a very fortunate insight. My own parents, my mother had dementia in the last 3 years of her life. I've just written up an account of this, which was very positive. And my father had perioperative cognitive impairment for the last few months of his life. So I'm kind of mindful we need to be thinking about, well, where do I fit in here? And I think the disability sector is a very useful phrase, which talks about the presently able-bodied. And I think those of us who are presently without significant barriers of cognition and language need to bear in mind our own futures. In the first instance, I'd like to point out the positivities. When I got involved in 1986 in dementia research, the Oxford Textbook of Medicine had recently come out, and in 2,500 pages had only 1 paragraph on Alzheimer's disease, one of the most significant, important causes of acquired disability within our populations. I became the medical director while only a registrar of the Alzheimer's Society of Ireland, a tiny group meeting in one small room in St. John of God's. So much has happened in the interim, and I think we need to be grateful when we look at the fantastic program today and see all the various areas which we've seen development. I'm particularly heartened, for example, we pioneered out in Tallaght on post-diagnostic counselling, and it's really interesting to see that appearing so prominently in the program. We have a national dementia strategy, which again, while not perfect, is certainly a move forward in a national dementia office. So there are very strong positivities. But if you go into any of the major teaching hospitals in Dublin, you'll find Monday to Friday, 9 to 5, a large cancer information centre. Yet dementia, which is equal, if not greater, in terms of its significance for populations. When we opened our memory hut one afternoon a week in Tallaght Hospital, this is the only hospital that has anything. So we can see that in terms of our preparedness, our engagement with the public, we still have a way to go. So of course, COVID really, in terms of stressing systems, it really is the lived out experience of Warren Buffett's that only when the tide goes out do you discover who's been swimming naked. And certainly in terms of people living with dementia, we know that in the community, we've seen quite marked changes, almost certainly due to the reduction in services, day centres, fears, concerns, insensitive use without partnering of lockdown and cocooning. And we've seen a worsening of, largely a worsening of memory with a very, very small amount of overall improvement. We've seen this also in terms of increased levels of caregiver stress. And increasingly, we're beginning to look at this more carefully to try and get the costs and the benefits sorted out here. But a neglected area, and perhaps this is where I'd like to bring our focus back to us as in advocacy, professional and research. To what extent have we engaged with a vibrant policy for high quality of life empowering and support in nursing homes. And nursing homes clearly are an area where dementia presents in its most complex, in an area which needs perhaps the most sophisticated and skilled support. We undertook one of the first studies showing a figure of about 60% cognitive impairment going from the census, and this goes up to 90% in the more finely tuned study by Suzanne Cav and her colleagues. And yes, what we saw was really quite tragic in many ways. And what we saw was this perfect storm, which was really underpinned by many determinants, whereby there was a generalized neglect of focus on what the needs were for older people with dementia, predominantly older people, but also some younger people living with dementia in nursing homes. And the first issue was the privatization, a policy of privatization without debate and without linkage to the health system by the Department of Health. And again, very few voices were raised about this. And indeed, this is probably the absolute foundation of our problems. It was then, what we noticed certainly in the United Kingdom is commissioning bodies seem to take an interest in actually what is the quality of care and indeed work with quality initiatives. But the NTBF seemed to be a fire and forget commissioning body without clear evidence of gerontological or dementia care expertise. In terms of the Health Information and Quality Authority, the regulations were inadequate in terms of the complexity and needs of care, without sufficient updating or input, as was the regulatory framework. But the question today to us is, what about us as health and social care professionals? And what degree of leadership and focus relative to the need and complexity of care did we see from the medical community, the nursing community, the largest group of professionals within the area, and other health and social care professionals? But the last question I'd put on this slide is that of the advocacy groups. And to a certain extent, for both health and social care professionals and advocacy groups, I wonder, are we somewhat in the position that oncologists many years ago were in when they regarded referral to palliative care as some form of a failure? Do we see progression to nursing home as a form of systematic failure? Or do we see judiciously used, and indeed nursing home usage has been dropping proportionately in Ireland over the last few years? Do we not see it as an integral and really important part for focus, attention, vision, and inspiration? So not only do we have a terrible death toll in nursing homes, but with high depression and anxiety for people with Alzheimer's disease living in retirement homes during the crisis. And what the crisis has shown, as I think is increasingly clear, the devaluation of nursing home staff, their supports, their inputs, their expertise. And this is an international group coming together from very many countries to say that, in fact, one of the worst things was people were saying, but it's terrible elsewhere, but it shouldn't be terrible elsewhere. And we've got to bear in the background that this really has brought out something we've known for some time, is that if we underfund, lack of a clear focus on expertise, on independence, on empowering, we're going to see abusive care. And indeed, the most recent study among primary care GPs in Ireland showed a third of them had seen substandard or inappropriate care, of which a quarter of them had not reported or undertaken any action. So clearly, we do need to do something. And I think in particular around visitor restrictions, which became a bit of a political football early on, I really feel that while in the very first few weeks, the first month or two, when we'd seen Italy, it was really important for us perhaps to take radical, drastic measures. It was increasingly clear that who brings COVID-19 into nursing homes are not visitors by and large, particularly with due precautions, but largely it's related to staff. But did we see people living with dementia in nursing homes and their care partners as people with whom we negotiated the issue of risk and independence and the idea of balancing infection control, public health with the right to a full and complete life? And it's quite worrying that there's a broader context. When I was doing I used Twitter as a memoir, and when I was putting up some of these papers here, I was really shocked to see a blasé and dismissive attitude from healthcare professionals. This is from one where, I was positing that there should be appropriate standards, but they are not Olympic training grounds or rehab centers. The idea that it was permissible in the public domain to put out this sort of an artificial, offensive and undermining dichotomy. But we saw this also, for example, within the Health Research Board. We were very concerned, wished to look at what was partnered with a range of stakeholders, put in a submission to the Health Research Board. Their external reviewer and internal reviewer processes passed this statement without comment. They said, but on the other hand, there's the awkward fact that many of the deaths have been of residents who were in poor health and would have died at some point in the next 12 to 18 months. To be fair to the HRB, when we pointed this out to them, they did apologize, but clearly everybody in the process is so inured to low expectations that we can see this sort of thing happening within our research and scholarship framework. So let's think about our skin in the game, those of you who are attending, those of you who are on a faculty for this meeting. While we do work towards maximizing supports to maximize care in one's home and community, how do I view the high likelihood of spending some of my later life in a congregated care setting? And we have a positive vision and realistic expectation for life in nursing home could and should be? And I really think the signs for how things are at the moment are not positive. And I think this is an opportunity for us to generate this type of debate. And when I look at the National Dementia Strategy here and in many other countries, strong emphasis on prevention, strong emphasis on treatment, strong emphasis on support to the community, a great big gap around what care in congregating settings should be, and then an extraordinary emphasis on palliation. Nursing homes are for living. Yes, we all will die in later life. We will all die, those who live with dementia, with a higher likelihood of dying in a nursing home. But this emphasis on palliation ahead of living actually troubles me. And I think we have a big question to ask ourselves about how we have developed perceptions of worth, status, and rewards of working in nursing homes. And really what sparked me in many ways that we could do better was when I was undertaking the review of Lee's Cross, I came across the national standards for residential care for children. And I have to say, it caught me in the throat. The fact that we could, in their own language, in a very empowering and supportive way, talk about if you're sick of a disability, you need special medicine, special food, that should be in your care plan. Everyone who's minding you knows about it. The care staff can make sure what you can get what you need. But the other elements as well. Every now and then, you and your family and your social worker and the care staff should get together for a chat about your care plan, see how things are going, review meetings. How do we do that in residential congregated care for older people? Your centre should be a happy place to live. You should be able to have birthday parties like other kids, be able to play sport or whatever your hobby is. Have your friends over to play sometimes. Also important to have one person who's specially in charge of you, knows you very well. And the health board has to give every child in care a social worker. Care workers were supposed to be, caseworker were supposed to be part of the National Dementia Strategy. And I'm presuming and hoping that we're not assuming that just because you're in congregated care, that you're not going to get that whenever this should ever happen. The current guidelines for residential care, congregated settings for children, again have this emphasis on new experiences, time for play, travel and leisure, hobbies and interested. Child's family is involved with care when it is right for the child, gets out and about, part of their local community. So, is this all doom and gloom? No, I don't think it is. I think we have the wherewithal and the opportunities, should we turn our focus and start accepting that life in congregated settings, there comes a point for care in the community, and I saw this with my own mother, where having a constant cavalcade of people through your home actually diminished what home was in many ways. And one of the good things that I've seen in the literature is the beginnings of a fight back. So this letter from the early days in Italy, where the nursing homes were effectively besieged castles, it's really good to see this wonderful paper from Canada. Samir Sinha is a pal in Canada, and the idea of partnering with people living with dementia and their care partners around sharing risks, about understanding the broader picture. And I'm really pleased that the most recent version, and great thanks to, I think, to the advocacy of Sean Fawn, Dr. Sean Kennelly and others, has really made it clear that visiting in nursing homes is an issue around compassion and appropriate mental health. So again, read those carefully. They represent a step forwards. I think also we need to start talking. Now, designing nursing homes is not a magic bullet. Our partner in Australia with whom we've worked on designing nursing homes says that if anybody comes to him asking about designing a nursing home, he says, show me your care pathways for dementia first. But actually the idea that we'd allow ourselves to build 200-bed nursing homes, built like institutional hotels on the periphery of cities, rather than small units in the community with a domestic and empowering and individualized setting, is somewhere where we can start. That's very clear. So coming near, I've tried to keep within the 20 minutes. COVID-19 must forge a sharper focus by us on congregated living for those of us living with dementia. I have to say, again, life is iterative, but certainly I felt that the focus in the National Dementia Strategy and the focus, for example, in the review of it, really lacked any sense of a vision for this empowering, supportive, and effectively inevitable part. When I did a number of radio pieces early on, I was so saddened, and it's very common out there in the public domain, where people say, I fear ending up in a nursing home. I'd hate to end up in a nursing home. And I think we've got to start working in our discourse, in our dialogue, in our presentations, in not really some form of patchwork onto a system that lacks this. And indeed, my worry about some of the very interesting initiatives in the UK in care homes, which are nursing homes with high levels of illness and morbidity and dementia, is attempting to patch up something rather than saying, hold on, we need more high-level expertise in here. And let's hope that we can work together and to a point where we can say, I feel secure that my wishes, comforts, and independence will be maximized and supported when I transition to nursing home support. Because truly, COVID-19 is indeed the great revealer, not for the system, but actually for ourselves as well. Thank you very much.
Thank you so much, Des. That was really brilliant and very thought-provoking. Thank you. I will now hand over to Deirdre. Deirdre is Director of Nursing and the National Lead for Older Persons Services Clinical and Integrated Programmes at the HSE. Thank you, Deirdre.
Thanks very much, and thanks for inviting me. Hard to follow on after Des, but I'll do my best. And it's funny in relationship to the discussion because we haven't talked, and yet I want to talk about my future older self, because that person is very important to me, and particularly in the context of life in Ireland at the moment. So when I want to talk about this person, I'm talking about you and I'm talking about me. I'm not talking about anybody else, others. And the fact that I suppose we need to rejoice in that we are going to live longer. So if you're a man, your life expectancy in 2046 is about 85 years compared to our parents, grandparents, great-grandparents who would have lived till 57. And if you're a female, you would have lived till 57.9 in 1926, but now we'll be living till 85 years of age. So that is a success. However, there'll be a lot more people doing the same thing. And you can see from this graph that in 2026, we'll have 860,700 people over 65, but that's going to grow to 1.4 million people over 65 in 2046. So I always ask people to do a little bit of maths and to figure out what year you're going to turn 65, and does this data stand out to you much more significantly then? And if you look at the number of 80-year-olds, and I plan on living until well into my 80s and being upright, but I will be one of a number of people. And in 2011, there was 128,000 people over 80. That's going to grow up to almost 500,000 people in 2046. And I'll tell you a secret, I will be in that age category in 2046. So there's a lot to celebrate about aging. And one of the most important things, I think, is the difference between chronological and biological aging. So this is Ernestine Shepherd. She's my hero, and I want to look like her when I'm 80. And she is 80 in this picture. She's 84 now. She's the oldest bodybuilder in female bodybuilder, and a super ager. The lady opposite her here is also 80. And I suppose the difference here is chronological age and biological age. So aging isn't the issue. The most challenging expression of population aging is actually frailty. And when I look at this, I want to consider my future older self, and I would ask you to consider how you're going to age. Let's just talk a little bit about frailty. It's a complex intermingling of biological, social, and cognitive factors that negatively impact on an individual's ability to independently complete their activities of daily living. It involves genetics, so we really can't do very much about that, and environmental factors. So your poverty, your education, the way you live, the environment around you, pollution, they all bring together and add to cumulative cellular damage. And if you added on top of that then poor nutrition, decreased reserve, and decreased physical activity, you have an increased vulnerability to frailty. Add in then stress or a stressor event, and COVID, as Des has said, is actually very stressful and can be seen as a stressor event. And if you're vulnerable to frailty, this might be the piece that actually sets you off the precipice. And that can lead you to presenting with instability and falls, being incontinent and having changes in your cognition. That then in itself leads to increased care needs and potentially admission to hospital. I really like this graph. It's really simple. Many of you will have seen it before, but it just reminds us in relationship to the vulnerability of frail older people to sudden change in health status. So if you look at the green line, a minor illness, perhaps a urinary tract infection, in someone that's well and fit, they remain independent. You can see there's a drop in their functionality, but the trajectory of their illness is quite short-lived and they return to the baseline. Someone who is vulnerable to frailty or frail can have the exact same urinary tract infection, but you can see that they will move from independent to dependent. The functionality decrease is more severe. The trajectory of their illness is longer, and they may or may not return to that baseline. And that's important because if we understand that, we need to recognize frailty. We need to plan for how we're going to support and care for those living with frailty in our community and in our hospitals. And when I'm 80, that potentially could be me. So I really am invested in the fact that we need to future-proof our delivery of our health services for the people who'll be using it. Because science says that more than likely as I age, that will be me. Frailty is a long-term condition. It shares the features of the typical presentations of long-term conditions. It's common. Up to 50% of people over 80 years of age have frailty. It's costly at an individual and societal level. It's typically progressive, but not always. It's potentially modifiable, and it presents in episodic crisis. And you can move from fit to mild to moderate and then to severe frailty. But if we consider frailty as a long-term condition, we can begin to apply internationally established models and implement evidence-based care. If you look at frailty around the country, we're all moving to Donegal. But frailty is quite prevalent in over 65-year-olds, around the country. So have a look and see where you live. 57% of public health nursing service users aged 65 and older are frail in this country. 22% of our ED attendants are over 65. 40% of our acute medical admissions, and 50% and more of our hospital bed days are taken up by people over 65, generally living with frailty. 5 to 6% of our older population require residential care, and that's the international trend, unless you live in Donegal, where it's 2.4%. Again, we'll be moving to Donegal. The bed capacity within the nursing home sector is no longer keeping pace with increasing demands for long-term residential care. And as Des is muted, that's probably not a bad thing. We need to be moving care to the home. I want to stay at home. Where do you want to be cared for? And in relationship to the demand for health services in 2030, so again, what age will you be in 2030? What does this mean to you? There's increased bed days, 37%. That's up to 1.2 million extra. Day patient cases will be going up. GP visits up to 27%. They're already taxed as it is. Home care packages will go up to 66%. Home health hours will be up as well. So we're going to be vying for care with an awful lot of other people. The sad thing, though, is that people see frailty like this. And I tend to work 3 or 4 times a year. I go visit the universities with the undergraduate nursing students. And I ask them using Mentimeter, which allows them to be anonymous in their responses to me by phone, to describe frailty. And it's exactly this. Skinny, wasting away, can't do anything, shriveled, doggery. So negative. And that in itself leads to the attitudes and perceptions. So within the report of the Commission on Nursing in 1998, older person services was seen as the least preferred place to work and seen as settling, as in there's no science in it. It allows for terms like bed blockers. There's no older person in the hospital bed wanting to be there. They want to be at home. It's the system that's blocking. A delayed discharge, labeling again and putting the fault in the patient's lap. Acopia, the most lazy of diagnosis. It means that the clinician has not looked to see what's going on, because behind every acopia is an infection, is cognitive impairment, is an inability to manage because of a reason. Poor historian. The only thing poor about this is the history taker, because someone somewhere will know something about this person. You need to look for collateral information. Pleasantly confused. This is such a misnomer. What could be pleasant about being confused? Yet we use it all the time. The one that gets under my skin and drives me mad because it others people is the elderly. That's someone else. It's not my future older self, it's the elderly, those weak, shriveled up people. Elderly shouldn't be used, it's older people. And we've added into this lovely dictionary with the vulnerable and cocooners. Those are the people that, as Des said, are not really of huge value. We can let them go. So unless we see frailty as a science and see those who are living with it, living with a long-term condition, this is going to continue. It's not good enough. It's not good enough for you, and it's not good enough for my future older self. And all that leads to this. It leads to the fact that in hospital, we cause harm to older people. There's a functional decline within those admitted over 75 years of age, based on this study of 615 older people. And you can see the baseline. And then in hospital is the middle bar. So you would expect that someone's functionality would be reduced, but look at the harm we're doing on discharge. One study highlighted that 65% of older people were deconditioned after 48 hours of being in hospital. That's 2/3 of people after 2 days. and 67% failed to improve before discharge, and 10% deteriorated further. But we don't measure this harm. Older people in hospital have a 23% risk of being unable to return home and to require nursing home placement simply because they've lost their ability in some of their activities of daily living, even during a short hospitalization. That's just not good enough. And evidence suggests that one in two of us will become incontinent within 24 hours of hospital admission. Would that be acceptable for you right now? It's not for me, and it's definitely not for my future older self. We know that 1 in 4 adults are physically inactive and spend up to 12 hours a day sitting. And that's even with knowing that you should do 30 hours of exercise, or 30 minutes of exercise every day. But when in hospital, adults could spend up to 73%, which is 20 hours in their beds. But it doesn't have to be this way. Let's change the narrative. If we empower people and let them know that exercise, getting up, getting dressed, getting moving, can maintain their muscle, then we will be able to ask them to spend some time exercising. Exercising won't be just about, I better do that for my heart. It'll do that for my future older self. If we have a look at the muscle mass, so this is the muscle mass of a 74-year-old sedentary male. You can see the muscle mass and the 40-year-old triathlete. You can see the difference in the muscle mass. And here's Ernestine again, a 70-year-old triathlete. Now, I'm not suggesting that we all go and become triathletes, but what I am doing is showing you the difference that a 40-year-old and a 70-year-old can still have the same muscle mass if they remain active. The other thing is about risk. This is a lady in Cork in the snow two or 3 years ago, went tobogganing with her grandson. You can have 2 comorbidities and still function quite well if you're socially connected, according to the research from Tallaght, and have those 2 comorbidities and be very frail if you're not socially connected. So this risk isn't something we would take for one of our patients, but it's something I would take for myself, and I should be entitled to choose my risk. So we just talk about COVID for a moment. So you can see that with this sense of quarantine and self-isolation and social distancing, that people's physical activity has reduced significantly. Their levels of stress have increased, and most people have put on the COVID stone. This has led to reducing vitamin D, which is really important, we know, for how we manage with COVID and also for muscle protein synthesis. And our bodies are changing because we're losing muscle mass, which leads to sarcopenia, which then will lead to falls in older people, and especially if they put on weight. And that leads to long-term health risks. So we're going to have a lot of frail people post-COVID. We need to get an understanding of frailty and start managing it. We're going to have an increase in cardiovascular disease and diabetes, osteoporosis and fractures, depression. We all know people's mental health is under pressure. There's going to be increased physical frailty and decreased quality of life. And the other thing is about malnutrition. So you can be malnourished and be obese, and you can be malnourished and be quite thin. It's about having sarcopenia, so muscle mass is so important. In relationship to diet, we know that 1 in 7 don't comply with the recommendations of the food pyramid. 3 in 4 don't get their 5 a day of fruit and vegetables. And 2 in 3 consume 1 or more servings of food high in fat, salt, and sugar. And yet diet is so important for our future older selves. 1 in 8 are vitamin deficient in this country, and this increases to 1 in 4 during the winter. So please get your supplements, give them to those you know, especially older people. And all of this is more common in those who live in the north and west of the countries, are overweight, less physically active, smoke, and live alone. So we put out a call to action. a call to action to get up, get dressed, get moving Ireland. And the purpose is to create a scalable, sustainable model of get up, get dressed, get moving that can be adopted and implemented at home, in the community, and across all health and social care settings. We've got nearly 200 members representing a wide spectrum of health and social care, universities, the GAA, CL Blue, Tilda, Sports Ireland, nursing homes, and the Age Alliance. So if you're interested in joining this network as a health and social care professional, or if you're interested in joining this from any other area within your workspace, then please do get in contact, because we need to get our country up, dressed and moving. We need to promote muscle mass, and we need to understand frailty as a long-term condition. It's amazing how good getting up and getting dressed and moving makes you feel for both your mental and physical health. Thank you.
Thank you so much, Deirdre, for that very interesting and thought-provoking talk. So I will now hand over to Professor Eamon O'Shea. So Professor Eamon O'Shea is the HRB research leader and the director of the Centre for Economic and Social Research on Dementia. So, Eamon.
Good morning, everybody. Sharing my screen.
Just take a moment, yeah.
Yeah. So thank you for inviting me to speak like this. I'd probably go back to the 1980s and sort of in terms of I'm still looking for a share screen. So yeah, still go back to the 1980s and sort of walking through a lot of things on aging and older people. And things certainly have improved significantly in terms of dementia, but in terms of sort of the research and about how people think about dementia. And I think that's reflected in, I think, the National Dementia Strategy. It's reflected in increase in resources recently and so on. But there's still a lot to do. And I think I was really, some of the material that Des covered certainly resonated. But particularly even before I begin to my own talk, it's a question in terms of where older people are positioned in society. I think we need to think really carefully about how we engage and think with older people in society. I think there's been a little bit of evidence, and very often I don't think it's deliberate, but I think certainly the voice of older people hasn't been as strong as I would have liked to have seen it in terms of engagement, particularly in the recent crisis or during the recent crisis, in terms of engaging them directly in decision making, whether it be about nursing homes as Des outlined, or whether it be about cocooning and other issues. I think that voice hasn't been as strong. So I think that backdrop, while diminished, is still there a little bit, impacting not just on public policy, but in day-to-day engagement and day-to-day thinking about the possibilities of age and the possibility of aging. And I think that's really necessary to say at the outset. And I think in terms of how we think then about what's coming, I think the slide you see in front of you now, in terms of, you know, is a resource allocation slide in a sense. It's saying, look, the number of older people are going to increase over the next number of decades. That will lead to an increase in primary care, an increase in demand for residential care, an increase in demand for home care, and so on. And all of that is correct, and all of that is true. But sometimes this is problematized as being seen as, well, you know, therefore, you know, the language of burden is often used, or the language of look what's going to happen. And I think that's a negative way of thinking about this. And it's part of the issue about how older people are viewed in society. And older people are us, to be quite honest. When I started this research, you know, I was still aging, of course, but I was a long way away from older age. Now I'm really quite close, to be quite frank, and there's a lot of living to be done, and whether it's living in communities or living in households or living in residential care, there is a lot of living to be done in terms of the next 20, 30 years for people in their 60s and their 70s. And I think it's important that we don't get wrapped up, particularly when we think, and I'm an economist by background, but particularly when we think about the economic implications. Again, I remember making a comment at a conference about investment in older age, and almost, you know, why would you want to invest in older age? But of course, there are many good reasons for investing in older age, which is subject of another conference indeed. But I think we have to think about this as being a proper investment in older age, and that has implications for funding that we're going to talk about later on. So in terms of strategic issues, well, I can't cover all the strategic issues at play here, but one of the issues is often seen as spending bias towards nursing homes, you know, and if you look at the figures, you know, we do spend twice as much on nursing homes as we do on home care. And of course, we need to spend more on home care, but I think we need to digest and interrogate that data to see, well, maybe we should be spending more on both, or maybe we should be looking at what goes on in nursing homes and increasing spending or new models of nursing home, which I'll talk about at the end. So that spending bias, I think, needs to be regressed, but that doesn't mean detracting or subtracting resources from nursing home provision. Because, to be quite frank, there's so much we can do, but some of it we can do without much resources, and some of it we need more resources. I think that's useful when we start thinking about the future. I think one of the things that is still really strong here, I think there is still, although there's been fantastic work done over the number of years, there's still a very large weak social model in the context of thinking about age and aging and where to age and aging in place. But family responsibility remains very high. And I think it's been very interesting. And, you know, there's a normative discussion to be had around that, really, about how we think about families and the role of families and the autonomy of people, older people within families, the autonomy of people with dementia within families, and also then, you know, categorizing the work that families do and interrogating the work that families do. And without families, to be quite honest, you know, much of the care that goes on in communities couldn't take place. That's not to say, you know, that the state needs to take over what family providers do, but it definitely does require us to articulate this in a much more open way and to address issues that family carers have, I think, in the context of the provision of care. We have, of course, the new home care legislation pending. I just hope it doesn't pending for too long, because we need to get that legislation in there, and of course we need to put funding around it. Now we may have to think differently about funding, but we do need an increase in funding. There's also the issue about slaughter care implementation and the whole issue of integration, which I think is a really strong theme, particularly the integration between nursing home and home care. I don't see home care and nursing home care as direct opposites. I would see them all, and indeed over the years, the sort of dichotomy of at home or nursing homes, both actually and within policy, has not served us very well. And I think we need to really think about the continuum and what the continuum actually means and how to address the continuums in an integrated way. Now, that's not to say there hasn't been progress, and there's a lot of people doing a lot of good work in terms to ensure that integration, but I think we have a bit to go there. We have, of course, COVID and its legacy and responses, but, you know, even if there wasn't a COVID issue, these issues about the lack of integration and also almost forgetting about older people in nursing homes, and we're all guilty of this in a sense, would still be there. I think what this has highlighted is the need to address these issues explicitly, and to see, well, what do we want how do we want care to be organised, how do we want care to be provided. These discussions should enter the public arena as what is person-centred care, what is the right design for nursing homes, what should be the relationship between a nursing home and a community should be. I have direct experience in nursing homes. I have direct experience of caring for people with dementia. And certainly that dichotomy, the other, it creates an otherness there, which feeds into then public fears about nursing homes and fears about aging and fears about the future. But I think that discussion can be opened up much more. And of course, it doesn't raise the issue of future funding models, which I'm not going to talk about this morning, but except to say that in the context of intergenerational relationships and solidarity, I think there is still a strong intergenerational solidarity here. I think that needs to be taken into sort of contractual relationships between young and old in future decisions about funding. And I think we have an opportunity now to really work on a model which taps into that intergenerational solidarity and allows us to properly fund both home care and residential care. So I just took a little bit, because there's been a few interesting publications recently. One is the House of Oireachtas 2020, the Special Committee on COVID-19, and there's some really interesting aspects that if we were to move on these, I think we could make progress really quickly in terms of taking advantage of this awful crisis regarding COVID to turn around the way we think about care, both at home and in nursing homes. And I think the opportunities are there, particularly in terms of integrated system of long-term support. I think the more work we do on the integration on this is really important. The focus on shifting care from congregated settings doesn't mean that nursing homes won't any longer be necessary, but I think we need to encourage both public policy or true public policy, but within public policy and within the nursing home sector and within the public, a new model of nursing home care, which essentially allows highly autonomous living within nursing homes with a huge degree of connectivity within nursing homes and to the outside world. I think this is a really key development. If we could ensure that through the sort of certainly we have a lot of we've seen where what can happen within nursing home. We've seen the impact of the absence of visitors. We've seen the absence or the influence of the absence of connectivity. We've seen the issue of staffing. All of these things can really accelerate policy if we wanted to. And I think this goes back to my first point about how we view age and aging, how we view older people, how we view that solidarity relationship, how we view our own futures, and I think we have really an opportunity to make something really special from our experiences over the last 6 months. These issues were always there, to be honest. I mean, they were there. I remember back in 1991 writing a review of the nursing home sector, those issues were there. They have been addressed to some degree, but some of those are still there, and particularly the integration of the private nursing homes to the wider framework of public health and social care. This is really critical as well. These nursing homes and residential care should not be outside the system. They should be part of a system. They should be part of the continuum. And it should be appropriate care at the appropriate time for the appropriate person. Not everybody can be looked after at home. So therefore, we need to have pathways, and we need to have a really we don't use these terms when we talk about aging like exciting or innovative, but we should be using these terms about residential care opportunities and different forms of living and different forms of lifestyle. We tend to see it as passive. We tend to see it as being. We tend to see a life in nursing homes or life in residential care as being passive, as being outside somewhere, as being not relevant to the day-to-day community or day-to-day social life, and therefore not relevant. That has to change. And I think there's many good examples of the residential care sector who are trying to do this. But I think it needs to be envisioned wholly. It's not just by the sector itself, not just by individual proprietors, not by individual managers, not by people who want this to happen. It needs to be taken on board in terms of a social view of what should the future look like. And I think for that to happen, there needs to be some sort of coming together of funding to allow us to fund what we want to happen. And that's not easy, but I think it is something that we have to think about. And in terms of, I know when people look at principles for change, their eyes gloss over, but there's a really important words here that all of us take for granted in our day-to-day life. In fact, we take it for granted that we're born into a society or an economic system or economic and social system that allows these to happen. It's only when you start taking things away. I mean, witness, when we're in lockdown or we're asked to restrict our movements, and we get really uneasy. The vast majorities do this because we know there's a social benefit, but it doesn't take away an uneasiness. So imagine yourself in a situation where just simply because you move chronologically, that you're simply getting older, that these things were reduced from you, and think about how that feels for people whose choice is taken away, whose flexibility, who are not included, who are not engaged in the day-to-day and normal things that we take for granted, that bring real goodness to our lives, that are part of our perpetual and continuous search for the good life in some way, and living that good life in a way that makes it meaningful for us and those around us, including sort of privacy and including, of course, then what wraps the whole thing up in a concept of citizenship. Imagine what life would be like when these words, who look just like, really, when you see a word like choice, you say, well, okay, so that's a word, choice, but now take it away. The choice to go for a walk, the choice to engage with people, with family, the choice to have a conversation. All of these things matter, but they only matter when we have a process to make them happen. We see when they're taken away how empty we feel, even though it's the right thing. But we must do something to make them happen, and we have been doing that increasingly with dementia because of the dementia strategy, and the last 10 years have brought accelerated change. But I think these are things we must continuously focus on in terms of that engagement. And in terms of on the right hand side of a policy frame, it's not to say that everything on the current side is wrong. It's simply to say there is also an element on the counter side that we need to think about. And social doesn't mean simply that you don't take account of the clinical aspects of dementia and the need for good clinical care. It simply means that we must think of social models within nursing homes, within hospitals. There is a social dimension to care wherever we go, and I think again it's to make sure we're aware of what's on the right hand side of the slide I'm looking at, for me, the capabilities are really something that and it's not just physical capabilities, it's emotional capabilities, the emotional capacity of the person with dementia, their care, their families. All of that engages for me as under capabilities. And of course, okay, assets is an economic language, but the idea of a person of investment in aging still resonates strongly with me. Without older people, imagine a society without older people, and in a sense, it creates a vision of the future, an intolerable vision of the future, because of what older people bring, because of what smiles on faces bring, because of what eyes bring when making contact. All of these things, in a sense, are in a sense the glue, in a sense, that makes societies work, that makes communities work. Even if there has to be separation, when people come together, I think there's that essence of connectivity is a real sort of virtue in society. So there's a lot of material we did in 2019 before COVID about the continuum of care, which in a sense is even more valued given the onset of the COVID-19 crisis. And the continuum of care that we did here with Fiona Keogh and Adeline Cooney really did set out a broad continuum of care that we need to work on in terms of the development of a range of possibilities. Some of them not so, all of those, I just listed them. I'm not making a case, I'm not making specific cases for any of them. If you look at the report, they go through advantages and disadvantages, but our own housing is a really important, and the adaptation of our own housing and the design of our own housing and smart housing is a real fundamental. And that's where I think the integration between housing departments and health matter a lot. And there has been a recent report the last couple of years which really points the way in this direction from the Department of Health and the Department of Local Government or Housing. But there are other aspects then, and housing with care is a really housing with care and technological supports is a really important, should be a really important focus of how we think about supporting people within housing, or how to, or even if that housing isn't their own housing. And then there is finally the whole issue of residential care. And I think the residential care aspect is, some of it has been addressed already. They need to think differently about residential care. And I would really urge the nursing home sector to begin that thinking, supported by public policy, supported by new investment, to begin thinking about residential care differently in terms of size, scale, and so on. And I'll point out in the next slide. And there will always be a case where you will have to have residential nursing care units for people. So I think we need to really explore in a continuum of care in a way that we haven't done, and that integration of that. And the rethinking of home, I think we need to think about intergenerational housing, independence through adaptivity, as I said, and all of that is necessary, and in my view, essential. How we think about home, where home is within communities, how we think about housing with care, and how we bring about the best version of home we can have within the residential care sector. And that goes back to the earlier things about what matters for people. Autonomy is particularly what matters. Independence is particularly what matters. Connectivity is what matters. And all of that is part of a rethinking of home. And any change is easy for some. Relocation is easier for some and not for others. But we need to create new models of being in place and at home. I think what the COVID has not told us, because some certainly people were aware of this before, we need to think about home in a way differently, particularly within both at home, in our own homes, but also in other places. And autonomy and proactive and the control over the physical environment and the person and the environment fit are things that we just cannot ignore any longer. Obviously, there is these have been covered within the nursing home sector. There's these issues, again, simple words on a page, but all of them resonate for the day-to-day care, the exploration of person-centered care, the things we talked about the humanity of care. All of these matter in terms of how care gets done. The scale, the numbers of people within a building, the staffing, the consistency of staffing, recognizing the professionalism of staffing through pay and so on, the design of the nursing home. All of these, by the way, some of these also apply to home care, the ethos of care, the critical word, the integration. Now, we talked a lot about governments, and the expert committee talked a lot about governments, and governments is absolutely vitally important. But the humanity of care in the physical environment that promotes humanity is equally important in terms of the provision of care within nursing homes. All of these measures, I hope you can see that I just pulled them out from the expert committee. All of these matters are really important in terms of sort of dealing with the current crisis we're in and any future waves and so on within nursing homes. But there is the broader issue then that we can't lose sight of in dealing with the immediate. We have to change this now. We've had really good progress. We can do so much now over the next 2 or 3 years, knowing what we do now and the impetus of what that intergenerational dimension that I think we can foster more right now to really bring about longer term change in the relationship between age, need, location of care, integration of care, and the primacy of the person within the caring relationship. And I would add to that the primacy of the carer and the family. I think this is a really important part of the addressing COVID issues, as well as issues to do with day-to-day governments and so on within nursing homes. So, there are models out there. I'm not, again, promoting any of these models. There's sort of greenhouse model, smaller community connections, smaller homes, the Tallaght model, all of these things. We have models that exist, but it's going to take courage to actually bring about the investment to support the nursing home sector, to support the community care sector, to actually, over the next 5 years, to redirect the way we think about care, the way we think about age, the way we think about autonomy, the way we think about community and the maintenance of community. If there's one thing this thing has taught us, if one thing this crisis has taught us, it is that when we become disconnected, we lose so much. And I think, if you're to ask me what I would like to see happening is that connectivity being central to the ongoing reform, and much more to the fore in terms of the ongoing reform, rather than thinking about particular sectors. Let's make this so connected, but to do it, I think we need a stronger resolution to bring about change. But I just want to conclude then. So, look, these are not novel conclusions. There are things to remind us that autonomy and choice really matters. These are not things that you give up easily, and you shouldn't give them up in older age. You shouldn't give them up in nursing homes. You shouldn't give them up in homes. You just shouldn't give them up as far as possible, as humanly possible. I know there are times when choice and autonomy are compromised, but But when we give them up, we give up so much, not just for older people, we give them up for each of us. The importance of place in the environment is absolutely central to the way we live our lives. When you take that away or diminish it, you diminish so much in your life. And people are telling us that, younger people are telling us this, and older people are telling us this. So belonging means just more than having nursing home beds available or having home care available. Belonging means much more than that, in terms of creating a sense of worth, a sense of being, a sense of living, a sense of loving, that goes on and on and on until it can go on no more. And I think this is a really important part of sort of the fabric of how of again what if each of us were asked what we'd want this. And I think we have an opportunity now to bring this together. And I think there is potential for a very different residential experience. And I think there's lots of people trying to deliver that right now. But I think we have an institutional possibility of delivering that. And by doing that, I think creating an environment where our society, where really that age and aging is central to the well-being of that society, because it is. So thank you very much.
Thank you so much, Eamon, for a great talk. And actually we have questions and comments coming in. So what I might do is introduce Susan, and then bring everybody together just for a short panel discussion. So Susan is joining us now.
Good morning. My name is Susan Cliffe, and I'm the Deputy Chief Inspector of Social Services within HIQA, with responsibility for the regulation of nursing homes. I'd like to thank Sinead and Grace and their team for giving me the opportunity to participate in this conference this morning. And I suppose essentially today, I would like to take the opportunity to give the regulatory perspective on caring for people with dementia. So the Health Information and Quality Authority is the independent statutory authority established to promote safety and quality in the provision of health and social care services for the benefit of the health and welfare of the public. The Chief Inspector within HIQA is responsible for registering and inspecting nursing homes where many people with dementia are living. And I suppose the purpose for regulating nursing homes is to ensure that residents living there receive an appropriate standard of care and support and are enabled to live their best possible lives. We act within a regulatory framework, a legal framework which underpins the regulation of nursing homes. And within that framework is the Health Act 2007 as amended, which is the primary legislation, an associated suite of regulations, just two of which are the Health Act 2007, focused on the care and welfare of residents in nursing homes, and the registration of designated centres regulations. In addition, there's an associated suite of standards, including the national standards for residential care settings for older people in Ireland, and national standards for infection prevention and control. The Act and the regulations set the minimum standard of care that must be provided for people living in nursing homes in order for registered providers to remain registered and continue to operate them. Inspectors of social services within HIQA are appointed to assist the Chief Inspector in registering and inspecting designated residential centres. And the team of inspectors who do this work are comprised of professionals with expertise in regulation and experience in either care of the elderly, general nursing, fire safety, infection prevention and control, occupational therapy, physiotherapy, and social care. And over the last number of years, we've really worked to expand the experience of inspectors so that we bring that broad spectrum and that social model of care to how we look at nursing homes. As of the 31st of December 2019, there were 585 registered nursing homes in Ireland, home to over 31,969 people. Now, undoubtedly, COVID-19 has had an impact on the numbers of nursing homes and the numbers of places, with some centres electing to deregister to provide an alternative model of care, and others reducing the numbers of people living in each centre. Nursing homes continue to increase in size, as evidenced by the average numbers of beds per centre, and also in the size of numbers of new nursing homes coming forward. Currently, the largest nursing home in the state has 184 beds, but there is a nursing home due to be registered in the near future, which will have 220. A total of 10 new nursing homes were registered by the Chief Inspector, and this is a positive development, as the new centres are generally purpose-built facilities with a majority of single occupancy en-suite bedrooms and ample space for circulation and socialising among residents, staff and visitors. This is in contrast to some of the older stock of nursing homes that have large multi-occupancy rooms and are challenged by inadequate toilet and bathroom facilities and small communal and dining spaces. The majority of nursing homes will accommodate residents with dementia. The difficulty we have is we only seem to have one model of what a nursing home should be. Since I came into this post in May 2016, there has only been one centre registered, which steps outside the model. Professor O'Neill earlier referred to this model as a hotel model. And increasingly, I agree, with the increase in size and the model that we have going forward, that is what we're having, large congregated settings. It's largely accepted that most people would prefer to be cared for in their own home or their own community for as long as possible. Home care, daycare, and supported living arrangements are care models that present people with dementia a viable alternative to long-term residential care and support a continuum of care approach. However, none of these care models are compatible with our current model of regulation, which is grounded in the definition of a designated centre. Professor O'Neill this morning described the regulations and regulatory framework as inadequate. I would have to agree with this assessment. Indeed, HICWA has recognised these problems for some time and submitted a paper on this to the then Minister and the Department of Health in 2017. However, I would also agree with the last speaker, Eamon, when he said that COVID-19 has presented opportunities and a new impetus to drive the reform agenda, and notably the reform of regulation. So if we look here in this slide, it's a pathway of care where a resident, be it an older person or a person with dementia, some of whom can be very young, are the options of care open to them. And this depicts the multitude of services that they may access during their lifetime. Notably, of all these services, only long-term residential care is currently regulated. With the exception of acute healthcare, where we monitor standards, all other services listed here fall outside the remit of regulation. If we accept that the purpose of regulation is to protect users of health and social care services, then we are saying that users of these services which are unregulated are not afforded this protection. Regulation of health and social care services may typically be described as an establishment model of regulation or a service model of regulation. In an establishment model of regulation, each physical location at which a care activity takes place must be registered, while in a service model of regulation, providers register with the regulator and informs them of the different types of care they are providing and in what locations. In an establishment model of regulation, the building rather than the care activity must be registered. This is the current Irish model of regulation for health and social care services. According to the legislation, the building or the designated centre is an institution. And that clearly still remains the language used in the Health Act underpinning the regulation. And out of that description falls the different type of buildings which can provide care. I suppose in relation to people with dementia, we're really talking about the nursing home as defined in Section 2 of the Health Act 1990. The current establishment model is not congruent with supporting effective continuity of care. So for example, if a company provides several types of care service, they're only required to register the service that meets the definition of a designated centre. HIQA inspectors have no power to inspect or monitor care provided in non-designated centres, despite the fact that they may be on the same site. For example, a residential long care facility and daycare services. An alternative to the establishment model of regulation is the service-based regulation. So if we accept the need for reform, maybe this is the direction of travel we should be looking at. So in RICWA in Northern Ireland, they regulate day services, home care agencies, nursing agencies, adult placement, residential care homes, and nursing homes. In that service model, they have different regulations to govern the care in the different models of service. CQC in England, also a service model of regulation, doesn't have a discrete set of regulations for each service, but does use fundamental standards which you apply to all services. There, you can select the elements of the fundamental standards that are appropriate to a particular setting. The COVID-19 pandemic has clearly highlighted current shortcomings, but has also provided an opportunity for reform. We need to consider other ways to regulate to ensure the safety of services. We would see the benefits of this approach in that it achieves the principal model of the principal objective of regulation, the protection and promotion of vulnerable dependent service users. We would have separate regulations tailored to the service model that a provider is providing. This would allow providers to be more flexible and innovative and bring forward other models rather than the large institutional type congregated setting or nursing home. We'd like to see the future of regulation framed in the context of service regulation. There are many government initiatives currently in play that make this a great time to critically review the current model of regulation. The work that is taking place to allow for the future licensing of hospitals, the regulation of home care, which was very much the agenda of the day before March of this year, or February of this year, when COVID took over. And now the COVID-19 pandemic. And indeed, you know, we have a very up-to-date review of the functioning of the nursing homes and care of residents in nursing homes that gives us a template going forward. So HIQA would like to see the future of regulation framed in the context of service regulation. As I've previously said, 2017 was the year that HIQA first published a paper calling for the reform of the current model of regulation and setting out the need for fundamental change in how we regulate health and social care services. More recently, COVID-19 nursing home expert panel recommended the review of these regulations in the short term. And I think, you know, when you go through that report, the regulations specified are very much linked to the control of infection. And that's short term, and we would absolutely agree that that does need to be happen. But equally important, that report calls for wider long-term reform as a key feature in the intended Commission on Care. Sorry. There are many stakeholders in this reform agenda. HICWA is but one. Key players in ensuring the safe quality services to current and future people with dementia include providers, staff, the Department of Health, interested parties, the public, commissioners, professional bodies, and families. But all of these must be peripheral to the people with dementia. Providers know their service best. They are familiar with the regulatory framework, and it's their responsibility to meet the requirements of the Act, regulations, and standard. So they are key to any reform of the regulations into the future. HICWA is needed to administer and enforce the regulations through good regulatory practices, and we are very much playing our role. We have amended the 2017 paper, which is currently being finalised, and we will reissue that to the department in the coming weeks. And then it is the work of the Department of Health, national policymakers, and key influencers to drive the agenda going forward so that we can all be part of the reform of this sector, so that we can all look forward to changes in the sector that will make this a much more inclusive model of care for people with dementia, which will transition from care in the home to care in a nursing home, because as Eamon did say, we will always need that level of care, but that the continuum of care will be safe, will be regulated, and will be defined, recognised, and funded. People with dementia must be at the centre of decision-making on how they receive care. This is true person-centred care. There must be a range of care opportunities available on a statutory basis, which would support all people in a range of circumstances. That care should be supported by regulations, standards, and safeguarding legislation. And most importantly, we need to move away from the current model of regulating buildings and centres to a model that focuses on services. Thank you.
Thank you so much, Susan. All of the talks for all of the speakers, they really have been very thought-provoking and challenging in some ways. I'm going to just turn everybody's video on now briefly, trusting it's okay. I propose we just run up 5 minutes extra just to give us a chance for some chat, because a lot of questions have come in through the Q&A and the chat. I will start with a comment on, I'll just bring everybody back into the room here, and Professor Kate Irving has joined us there as well. As I said earlier on, Kate is our academic partner. So there were a lot of comments there about different care models and attitudes and approaches to the care of older people. Just picking up on a few there, Susan commented on the focus on infection control, and then the need to relook at the regulatory framework. Eamon commented on the need for home. Deirdre commented on biological, chronological age and the difference in those two wonderful photos. And Des commented on palliative care. I wonder, and this was a question that originally came from Kate, What would anyone feel about the human rights approach, taking that human rights approach? Might that be a helpful way to go?
Yeah, if I can just come in here, I suppose the real challenge here is the lack of professional and other advocacy from within. There's an absolute, we've just undertaken a bibliographical review of research in nursing homes in Ireland, and so little of it comes from within, and so little of it comes from within the various professions and groups we'd expect to see it happening. So of course we should have human rights, but the key issue of human rights is people to understand, interpret, and exercise them. So I think it's important, but not sufficient.
I think I was meaning more along the lines that I completely agree with you. There just isn't the leadership from within, and that's why in reference to Susan's talk there, the kind of you know, looking at in detail is going to uncover some difficulties, I think. But I was sort of more meaning, could we take a human rights approach to look at the more structural reasons why human rights are challenged? I mean, the very fundamental thing of the new nursing homes that are being built almost exclusively on greenfield sites out of, that's a real challenge for Eamon's connectedness principle. That's one of the most fundamental principles of so I completely take you, and I would never minimize the point that you make there, as of course there's a much need, because ultimately this connectedness is about a relationship between two human beings. That could be a care staff and a person with dementia, or an older person in a nursing home. So even if the structural things were all in place, as I'm sort of saying, the human side of human rights needs to still be there, because fundamentally person-centered care is about bestowing personhood on somebody, and that can only be done in relationship. So of course it's about internal, but I do think that the external things, the more structural things that mean that we have large nursing homes built out of towns, says something very fundamental about what we think of older people and where we should put them. And I think, that also implies something to human relationships.
Yeah,
So
just from
and
Deirdre
just
in there. Oh. Okay, Des, yeah.
Quickly say, the European Commissioner for Human Rights also said that there was a key issue whether the rights of all those people who died had been undermined by lack of provision of adequate care. And so I think you're absolutely right. And the Oireachtas Committee also said there must be an external review of the adequacy of care of all those people. So the human rights dimension is absolutely critical. You're right.
Deirdre, you were going to.
Yeah, Kate, I think it goes even deeper than that. It's about the ageism in society. I mean, we are ageist, absolutely, considering we're all going to age. What's the other option? So I think trying to address aging and being a disruptor in many different ways. It's hard to disrupt in a system that can penalize you. So it's about disrupting in many other ways as well. So I think there's a lot of quiet disrupting going on, that might not be so vocal, and supporting proper ways of working. But yes, I mean, I think about my own father, and he's got dementia, and he is living his best life in a really person-centered environment. It's a small community of 8 people in each lodge, and that works really well for him, and he's happy. I don't have to worry about him. So that's what I want for every other citizen in this country.
I think as well, though, as Eamon said, it's a time now. It's timely for reform. We could do an awful lot in the next 2 or 3 years. And in essence, the first thing we have to look at is the model of funding, because our current model of funding, is what's driving these large buildings with increasing numbers of people living in them. Now, the average nursing home is still sitting between about 50 and 85 beds, but the trend is to bigger and all the time. And it's driven on a model of economies of scale. And the tragedy is, as this is happening, more and more of the smaller 20-bedded, 25-bedded, 30-bedded nursing homes that were real mom and pop industries, and the residents were very much part of nearly a family there. They're closing because in essence, the financial model underpinning those institutions or those nursing homes didn't support them going forward, didn't support them to make the fire safety changes that were required or to meet the requirements of the regulations. And that's what's been lost. And we really need to stop and think, is that actually what we want? And I think if you were asked the vast majority of people looking forward to living or the possibility of living in a nursing home in the future, that's not what they want. Now, that's not to say that the care, you know, in larger nursing homes, people are trying to work on the basis of household models, but it's much more difficult to do. And just by virtue of its size, it does take away from that person-centered approach sometimes.
Because we can use public policy to change things. You know, public policy is an agent of change. So once we get some sort of consensus, you know, or some informed consensus of what we need, you know, incentives do change behavior in terms of where locations happen, scale happens, or sorry, in relation to scale, in relation to design. And I think that's the shift, I think, the practical shift that has to happen. It's actually to use public policy in a very proactive way to achieve what seems to be a consensus about the primacy of, you can use your words, and I would certainly support that, Kate, in terms of a rights-based approach, but it also can be used as a person's, you know, whatever words mean we can achieve this, the care that is in essence the sort of the human type relationships matter, connectivity matters, and have some sort of primacy of autonomy and is living a good life. That what Des spoke about earlier, and he said, no, the necessity of people being able to enjoy a life at all times. I think our task is to get policy. Is to find ways, innovative ways, to find the incentives, the arrangements, the funding arrangements, and so on that allow this to happen.
And if you look at that broader government policy, it's not just the Department of Health. Like if you look at in the UK, it's actually the government planning departments that restrict the size of nursing homes, completely external to the Department of Health and their social care services. So that I'd agree with that, but it's across government policy changes that are required.
Yeah, Nisha Joy from CareBright has just come in here with a comment. Nisha is going to be speaking tomorrow actually on a session that's going to be focusing on residential care. And Nisha's commenting on that having the right environment being the key to quality of life, and then the need at that broader level for the government to really be on board and promote that household model of care, because without that, it's just not going to happen. To change the topic for a moment, there's a comment that's come in from Anne-Marie talking about moving the focus away to the community, so that sometimes there is too much of a focus on nursing homes and residential care. And then how do you deliver on that? That community supports needs more prioritization, and then it would in turn the economics alongside that. Maybe Eamon, you'd like to start with a comment on that.
Well, yeah. So I think just to acknowledge the work that's been done in recent years, in particular about shifting attention to social and psychosocial elements of care, not only at home and communities, but also in residential care. I think there's been a definite shift in terms of engagement in terms of home care, and obviously, you know, the work that's been done now in the sort of legislation on home care is going to mean, you know, fundamental changes if we support it, of course, with resource allocation, which is important. And I mean, there is good evidence that if you invest in home care, that more people can live at home. And I think, but again, it's a much broader perspective you know, we talked just in your earlier comment there and talked about sort of regulation of nursing homes, but also you have to make homes a better place to live. You know, our own homes have to be better places. We have to live easier to home. Communities have to make aging better to live, you know, and better for other people to get around and connect and so on. So it's not just a case of, well, if we had more services, of course, you know, we always want more home help and home support hours, but connectivity is beyond that. It's to do with how you organize and structure our communities and so on. And that goes back to a fundamentally broader picture of how we think about aging and how we think about older people's engagement and, I would say, visibility within our societies. I mean, you know, it certainly is, you know, the necessity to have older people central to the well-being of society is absolutely paramount for public policy making.
And of course, that's something that Des, you talked about quite a bit earlier on as well, that whole changing the narrative around aging and getting older. And as Deirdre said, you know, our future self. Would you have any further comment on that, or Deirdre, would you have any comment on that whole changing the narrative around that public narrative around older people in order partly to support people to stay at home within the community?
Well, I think it's an iterative process, and I think the understanding together, for example, was an important first step, but it really focused on people possibly milder stages, possibly in the community, and that was probably how it needed to be built out. But our aim understanding to be together should be that understanding of 100% personhood, regardless of your stage of dementia, and how we liberate and empower. So I think we need to keep going and making it more profound, and I'm sure I won't find any opposition to that.
I think there's a sense of fatalism about aging, and particularly if you have a diagnosis of dementia. And if you look at the champions, the Jacinta Dixon, I think of, who's worked with us on the National Transfer Document, and it's about keeping people in view and not hiding people away, because the more we see of people who are older and who are successfully aging or who are aging with long-term and chronic disease, the more we'll be able to see them as active and participative members of our community. And it's when we hide people away that they become the other, and we don't relate to them. So we need to be relating to our future older self and how that might look. We need to be educating ourselves about how to stay well for longer. And that doesn't always mean that you will, because genetics kick in and environmental factors. But there's a sense of the elderly that is just so negative, and we need to change people's attitudes, change the narrative. And if we don't start talking now, in 30 years when I'm 80, then I'm going to be living the life of that other person, that other group.
Of course, cocooning, that brings the whole notion of cocooning in. I know a few speakers commented on that earlier on. Do you feel, in terms of the attitudes, the public attitudes towards aging and supporting people who are older, has that had any kind of a medium-term impact, or on the people themselves and society in general? Has anyone seen?
Deirdre have done a lot of work on older people and volunteering, and from 75 years of age, older people seem to stop volunteering, and that's whether it's I'm too old to do that now, or mommy, you better not be going out and doing that, you need to look after yourself. And that whole sense of that risk averseness that we have for others. We're much more risk averse for others than we ever would be for ourselves. And I always show that video of the lady sledging down the snow, because if she was my mother, I'd be saying to her, no, I don't think that's a good idea. But look at the fantastic smile on that lady's face, and why would she not do that and have wonderful memories? So the cocooning and hiding away has made people feel afraid, and alone would come back and say that there's a huge amount of fear, because we have told them you're not safe. And what is not safe about going for a walk and keeping active and enjoying your environment like a 25-year-old? Why is a 25-year-old allowed to go out and to take that walk, but you better stay in now? And then you're more at risk of falling, so you better stay in. so you just better stay in.
Yeah, it shows still a troubling mindset of paternalism, of objectification, of simplification towards older people. Sadly, a reflection also of the Citizens' Assembly. So there is quite a lot of work to be done. We should have, after the first month, the issue was one of partnership, of risk sharing, of dealing with older people and those around them. And I'm really troubled by older people who are almost being pressured by their younger adult children, but don't go out, mom. So we've created an unfortunate paradigm, but it's also one that those with an interest in the area can say, actually, this is something we can see that remains a key issue, and we must develop partnership and respect risk-taking and responsibility of older people and people living with dementia.
I think the balance of risk approach just didn't play out well at the start of the pandemic. It was all about risk of getting COVID as opposed to the balance of risks of other things happening. And that's been, but I have to say, because I'm a carer of somebody with dementia, and from my experience of working with the healthcare professionals in the memory clinic that I go to, there was an absolute balance of risk approach when I finally got there to got mum into there. There was a balance of risk approach, and so somehow that didn't translate. And I think it was probably and this is some of the problem, I think, of what everybody's saying is we don't like to nuance what we say about anything in health, because we don't think that the public are educated enough to understand a more nuanced message. And this is fundamental. We've got one of the most well-educated populations in Ireland. We have a well-educated population who do understand more nuanced health messages, and I think this is what, and dementia is one of that. There's nothing simple or straightforward about dementia. It is a nuanced thing. It's not simple. Even the message about risk and dementia and the stuff Deirdre's saying about keeping active, and it is very nuanced. But I think that the public could take a lot more nuance than the press certainly would have our public consume.
And just before we finish there, I will, first of all, I launch a poll, if that's okay, just asking people who have joined us for feedback. And I'll just end here with a question for Susan that's come in. A couple of comments have come in about the new home care legislation. And I suppose it kind of follows on nicely from that discussion in terms of care in the home and safeguarding care in the home. And of course, at the moment, home care services and that. What's the story in the legislation in terms of the time frame?
I honestly wouldn't have an update on that. I would have said back last February, March, it was proceeding at pace and there was a real impetus behind it, but there's no doubt that the current pandemic has impacted on that, like many other things. My understanding of what has been done to date is it will largely be built around the Health Act and structured in regulations, such as the regulations that are in place for designated centres for adults with a disability, albeit it's the service care providers that will be regulated, not people's homes. It's those who provide the care that will be regulated. But I honestly don't know. Eamon might even have a more up-to-date on that than I have. I mean, it was this time last year that we met. Eamon organised a forum in relation to home care. But I do know there's a recognition of the requirement for it. There's a recognition of the urgency in the issue, but I don't have a date for when it will come out.
No, I don't either. Sorry, no, I am not consulted by the department on the dates. But I do, just when wanting to do with the home care and technology, I think we didn't maybe dwell in this area, but we're now interacting and communicating in a technological way, which I certainly, in any case, would have been alien to me 6 months ago. And I think technology and how we actually engage in a way with people and older people and services, I think there's possibilities here that reverts back to innovation. I think we shouldn't see the future as being the same as the present. And if we can manage to think differently about the future, I think we could be really creative. If you think of the impact of the internet and those big major structural shifts that have occurred, that have changed economic production, and now it's changing the way we socially relate. This crisis is changing the way we actually socially engage. I think there's something to be got from some people thinking about the future differently in terms of care.
One other thing as well, I think that we do need to take account of, and that is the workforce that's going to be needed to drive this care in the community. And that now is the time for stakeholders like the colleges, the professional bodies to be, positioning themselves and their members to be able to deliver the workforce. Completely agree with what Deirdre said when she spoke to the Commission of Nursing in 1998 and the position care of the older people had at that time. But I think we've moved on a long way since then, and there's quite a significant percentage of people working in private and public nursing homes now that have gerontology qualifications, social care qualifications. But it's going to be the one pool that providers of home care, interim care, respite care, nursing home care are going to be pulling from. And we need to be, again, from a policy perspective, thinking about this and thinking about how we're going to enlarge that pool. Because we're equally pulling out of it for our inspectors, and how we're going to future-proof that pool going forward. I think we're in a different place where it is an attractive place to work now, but it's about, at the moment, predominantly 80% of the service are private providers, and there is an issue in terms of terms and conditions available relative to statutory careers, if you like. So that needs to be looked at, that needs to be addressed, and the sector needs to be resourced. So it'll be one thing to have the models of care, it'll be another thing to have the regulations there to regulate it when they're there. But if we don't have the people to work and provide the care and support the people as they look to live at home and remain in their communities, we'll be at nothing.
I feel I need to come in there because I've been working with the National Dementia Office for a long time now, far too long, to make a really, really good, strong level 5 training for home care workers in dementia. And we are about 90% of the way to getting that accredited with QQI, and it's going to be delivered by Irish Times Training, because that's who the HSE have the contract with. And the next job, and Mary and myself were chatting about this on Friday, last thing on Friday, is we have to find capacity of people, the numbers of people we need. There's about 20,000 home care workers, so this is very few of them. We've trained about 1,000 people while we've been piloting and kind of getting up to speed with that, but there's that's less than 5% of the people probably that we need to train. Every single home care worker needs to be trained in dementia, and this is something we're working towards. And that's why the kind of the legislation scares me a little bit, because we're a long way off where we need to be in terms of having that workforce, like you say, Susan. So any kind of more carrots than sticks would be really good, because it is a mountain we have to climb. But what I can say is, hand on heart, and I've been really, really strong on this, is that in order to teach home care workers in the model that we've designed, a lot of the quality is in the facilitator, because it needs a strong challenge and that needs a strong support, and that's quite a difficult facilitation job to do, and we don't have enough numbers of people with that set of skills to train the home care workers. Well, we do. That's not quite right. I mean, there are loads of people, but they're all fully employed in really important jobs like ANPs and CNSs, and so there's we're taking, like you say, we're taking from that one pool of people. So we really need to vastly expand the numbers of people set to who can really facilitate in this way that forces people to examine what they think of as person-centered care, and that does necessarily mean examining that some of the care that they've delivered with their best of intentions has been not at all in keeping with human rights or in keeping with person-centered care, and it's quite challenging. It's a challenging course to facilitate, and we just need much more capacity. So we need many more people trained, like you say, but we need many more facilitators who can facilitate such a program, because learning to do this, I think there was a question, somebody asked a question about teaching compassion. It's a complex thing. You can teach it. I'm absolutely, like, some people say you can't teach compassion and people either have it. That's absolute rubbish. Of course you can teach compassion. You can teach the building blocks towards compassion, and some people will be predisposed to be able to feel that more easily, but it doesn't make them any better than somebody who has to learn that. In fact, Kant would say that makes the person who has to learn that a much stronger, more virtuous person. So I think there's, and it feels, constantly feels like we're scraping around for little tiny bits of funding to try and put things in a band-aid in place, and it's just not being funded in, and the size of the mountain that we have to climb in terms of getting 20,000 people educated is huge. So don't be too hard with the regulations.
And on that note,
if the Tooth Fairy was still listening after that, and I got the numbers and I got the education, the next thing I'd be looking for is the professional association. And, you know, in fairness, I do know many of the private nursing providers are already working on looking at this in terms of getting that sort of CORU registration for carers, you know, to bring it up to that professional level as well.
Okay, thank you so much. On that note, we will have to end, I'm afraid. Thank you so much, everyone, for your presentations and for the lively discussion. And actually, our next session is going to be supporting people in the family home. And Dr. Eamon Begley from National Dementia Office will be chairing that. So that starts at 11:30. So people just use the same link to come in here. I'd encourage people to continue the conversation on Twitter. Des said you said you're a big Twitter user, so feel free, if there are comments that came up or comments you'd like to make, feel free to participate there, and for the attendees as well. Our Twitter handle is @EngagingDemIRL, and we have a hashtag DementiaConf20. So do feel free to join the conversation. And thank you again. A lot of thank yous coming in for everybody. So thank you so much again, everybody.